Welcome back, everyone. This is Ahmed Radwan again, and we are at page 322 in Surgery, Master of the Boards, USMLE Step 3. We left off at acute appendicitis and would like to start right away. So let's do it. We have 25 minutes and would like to finish as many pages as we can. Okay, so acute appendicitis here. We are talking in general about acute abdomen or surgical acute abdomen. And this is the last inflammatory or inflammation disease along with the chronic ulcerative colitis. So acute appendicitis, it presents as follows. Really easy. Most people actually don't really confuse it with anything, but it is classically begins with anorexia. This is followed by vague umbilical pain, which several hours later becomes sharp, severe, constant, and then it localizes in the right lower quadrant of the abdomen. Of course, there is going to be tenderness and guarding and rebound tenderness and so on. They are found in the right and below the umbilicus, but it's not going to be anywhere else in the body or anywhere else in the abdomen or the belly. And that's really important here. It says here, as a side note, there is something called the Rovsing sign. It's by palpating the left lower quadrant increases the pain felt in the right lower quadrant. Of course, there are a lot of different other signs, and I think we should know it, like the psoas sign, the obturator sign, and so on. If you are a physician or somebody who is practicing at least for 1 year, you would know these signs. Go look it up either on Medscape or whatever website you would like to look it up at. Anyways, diagnostic testing here, what we're going to do. Well, usually we look for fever and leukocytosis. That's going to be 10,000 to 15,000 in range. We're going to see neutrophilia in immature forms and so on. But this is not specific. If the diagnosis here is unclear by clinical history, for example, and by examination, the best imaging study is a CT scan. Sometimes they do ultrasound, but this is less optimal. It's just something that if it is positive, then it is positive. But if it is negative, it doesn't mean that that patient doesn't have appendicitis. So, okay, if you have a CT scan, do it. How are we going to treat? Well, first we're going to administer IV antibiotics before the appendectomy. This is important. We can give Cipro and metronidazole, ampicillin, sulbactam, levofloxacin, and clindamycin, cefoxitin or cefotitan, and so on. This is just a repeat of what we said before when it comes to inflammation or a suspected infection below the umbilicus and the GI. Now, what if the appendix is perforated, though? We will continue the IV until fever and white blood cell count have normalized. So this is important. So if a perforated one, of course, this is really bad, but we're going to continue the IV fluids and we're going to continue the antibiotics until the fever and white blood cell count have normalized. But of course, you're going to take out the appendix. All right, so this is appendicitis, straightforward, easy. Now let's see what we have in chronic ulcerative colitis here. Well, chronic ulcerative colitis it's managed medically most of the time, at least. Surgery is usually elective, and it's the answer under specific conditions, and we're going to say what those conditions are. First, if the disease has been present more than 20 years, so that's when you think that there is going to be malignancy at some point here. So high incidence of malignant degeneration. Excuse me, I'm sorry. We should think about surgery after 20 years. There has been multiple hospitalization. This is going to increase the burden on the patient, of course. The third, the patient needs chronic high-dose steroids or immunosuppressants. So surgery could be an option here. It's going to be better than high-dose steroids for such a long time and the immunosuppressants because of the side effects. And finally, there is a toxic megacolon. Now, this is this is not something that is chronic, it's usually acute, but if there is a toxic megacolon, we're going to see an abdominal pain, we're going to see fever, leukocytosis, epigastric tenderness, and it's going to be a massively distended transverse colon on the x-ray with gas within the wall of the colon itself. This is a megacolon, a toxic megacolon, and you need to intervene right away. As a basic science correlate here, it says that ulcerative colitis extends from the anal verge in an uninterrupted pattern to the entire colon. So this is how to differentiate it between from uh, Crohn's disease, because it's going to interrupt its skip lesions, and it's just not in the colon itself only. All right, so we are done here with the inflammation, and let's move on to ischemia. Okay, ischemia, it starts on page 323, and when we are thinking about ischemia, we should consider the following here. First, the acute mesenteric ischemia is going to be in old patients. It's going to be with patients who have history of arrhythmia, like atrial fibrillation, for example, because they're going to shoot emboli and they can cause ischemia. It could be somebody who has coronary artery disease, so atherosclerosis and so on, and someone who has recent MI. Those are the things that we consider most of the time when we think about ischemia. As a basic science correlate here, it says that the intestine is supplied by three major gastrointestinal arteries here. We know that. They arise from the abdominal aorta. It's the celiac axis, the superior mesenteric artery, and the inferior mesenteric artery, and so on. All right. Easy correlation here. Oh, well, okay, let's say classically here, how is the pain going to be? Well, classically it says that the pain is going to be out of proportion to the exam. It's going to be the diagnosis is going to be clinical, but we look for acidosis and signs of sepsis. So again, we said two things here. The pain is out of proportion to the exam, kind of like what? It reminds me of the pancreatitis. Yeah, that pain is out of proportion to the exam. The diagnosis here is going to be clinical. That's the second thing we said, but we should look for acidosis and signs of sepsis. So we're going to do an ABG. If ischemia is suspected, we do not wait for the lab findings, like the acidosis and the elevated lactate. Now we just go straight away into surgery, or we order an angiography. So we don't really do anything like lab or stuff like that. If we suspect ischemia, we should not wait. We should go ahead right away and do the surgery or order an angiography. So if diagnosis is during surgery, we perform embolectomy and revascularization or resection. If the diagnosis is during angiography, we give vasodilators or thrombolysis. So this is the two things that we do here. If we have gone to surgery right away, we didn't really order angiography, we should do embolectomy and revascularization, or we can do resection right away if it's a lost cause. But what if we have done angiography? Well, we diagnosed it, we give vasodilators right away and thrombolysis. Okay, or thrombolysis. It says here CCS tip, whatever that is. When you think a patient has an acute abdomen or one that may become acute, make sure to get a surgical consultation on the CCS, whatever that is. The consultation will not offer useful information. The test is checking if you know to get surgery involved. Well, okay, I don't think this is for the USMLE Step 2, so we should really ignore that tip here. In USMLE Step 2 CK, you should not consult with anybody at all. We should know the answer for everything. All right, a basic science correlate here says that the most common vessel affected is the superior mesenteric artery. This is due to the acuity of its angle, and because it's a direct branch of the aorta. Okay, so we should think as a common vessel, superior mesenteric artery. Remember that. All right. Awesome. Okay, so far we're doing really well. Now let's talk abscess. First, we're gonna talk about the intra-abdominal abscesses. We consider the possibility of an abscess if any patient with history of a previous operation, for example, previous trauma or intra-abdominal infection or inflammation. That's when we consider an abscess in a patient. An abscess, it can occur anywhere. Either it is in the abdomen itself or retroperitoneum. Okay, so how are we going to diagnose that? Well, we diagnose it with CBC and a contrast CT of the abdomen and pelvis. So we need contrast CT so we can see the abscess. We're going to treat it, of course, to always drain an intra-abdominal abscess, either surgical or percutaneously, and we give antibiotics to prevent the spread of infection. And this is just not for the cure of the abscess. That's very important to note, not to cure the abscess. The abscess is going to be drained. That's the only thing to do here. Finally, we are getting, we're getting into the surgical jaundice. This is a very important topic here. Surgical jaundice, it's going to be the obstructive one. The first topic here is the obstructive jaundice caused by stones. It says here that the question will describe an obese, fecund woman in her 40s with the following signs. So that's going to be a woman. That's more likely than men. It's going to be obese, more likely than a thin individual, and has the following signs. It's going to be recurrent episodes of abdominal pain. It's going to be high alkaline phosphatase. Of course, it's not specific, but it is sensitive, and dilated ducts on sonograms. It's going to see or say a non-dilated gallbladder full of stones, and it's going to be direct hyperbilirubinemia. Importantly here, it says, as a basic science correlate, the common hepatic duct and cystic duct merge to form the common bile duct, which merges with the pancreatic duct and allows enzymes and bile exit to the sphincter body. So we should know that. It's really easy. What are the diagnostic testing? We said sonogram, so an ultrasound would be really good. To confirm, we can do an endoscopic ultrasound or a magnetic resonance cholangiopancreatography, MRCP. So a sonogram, that's going to be sufficient most of the time, but we can confirm with a endoscopic ultrasound or an MRCP. It says here as a side note that ERCP and EUS, or the endoscopic ultrasound, are never the first step in diagnosis here. ERCP is most often a management step on the exam. Okay? All right. So, how we're going to treat, we're going to do the ERCP with the sphincterectomy, and then cholecystectomy should follow. Okay? All right. Now, this is by stone. Well, how about a obstructive jaundice, but it's caused by the tumor? If a patient with progressive symptoms in the preceding weeks, and if he's going to have weight loss as well, we can suspect that this patient might have a tumor. Of course, also with old age. Excuse me. Well, what kind of tumor should we think about? Well, the first that most people actually think about is the adenocarcinoma of the head of the pancreas. But sometimes it can be the adenocarcinoma of the amphilevator or the cholangiocarcinoma arising in the common bile duct itself. So that should be suspected. So not only the head of pancreas. How we're going to test that? First, it's going to be a sonogram. It's going to show the obstructive pattern of the jaundice, and I think we're not going to see any stones. We might, but we are not likely to see stones, and it's going to be a dilated gallbladder, I think. Okay? But also we can do a CT scan. For lesions seen on the CT scan, we obtain a tissue diagnosis via an ultrasound, but an endoscopic ultrasound. We can obtain a tissue here. If there is no lesion seen on the CT, we can order an MRCP, which will show the ampullary or the common bile duct. Tumor itself, not seen on the CT scan, and we can obtain tissue diagnosis via ERCP. So again, we're going to do a sonogram. If we don't see anything, we can do a CT scan. If we see anything on a CT scan, we can do an endoscopic ultrasound and get a tissue sample. If we do not see anything on a tissue, an endoscopic. I'm sorry. We said if we do not see any lesion on the CT scan, we order an MRCP, which will show the common bile duct tumors, and then after that we can do an ERCP to get a tissue sample. And of course the management is surgical resection if possible. All right, now let's move on to gallstones. In gallstones here, we're going to talk first about the biliary colic. The biliary colic is going to be temporary occlusion of the cystic duct. Its cause. It causes colicky pain. I'm sorry. It's gonna it's gonna cause colicky pain in the right upper quadrant. It's radiating to the right shoulder and back. It's gonna be often triggered by fatty food. This is a typical episode here, and it lasts for 20 minutes, for example. And there are no signs of peritoneal irritation or systemic signs. We diagnose it, of course, with a sonogram, really easy, and we treat it with elective cholecystectomy. An acute cholecystitis, however, is different. It's going to be persistent occlusion of the cystic duct from a stone, which will cause constant pain. So this is different. It's the biliary colic. It's going to be episodes, which are brief for 20 minutes, and it's going to be colicky pain. This is different. This is constant pain, and it's going to be with fever, leukocytosis, and it's going to be peritoneal irritation in the right upper quadrant. So that's different. Peritoneal irritation, that's different, because we do not see peritoneal irritation with just simple biliary colic. As a side note here, it says that Murphy's sign, which is very famous, is pain on palpation of the right upper quadrant during inhalation. So you put your hand in approximately on the right the right upper quadrant, and approximately across the ninth rib, and you ask the patient to inhalate, and if you see the patient flinching or says that he has pain, then that's a positive Murphy sign. Okay, the diagnosis here is going to be with a sonogram, which will show a gall stone, of course, and it's going to be a thick-walled gallbladder, which is a sign of inflammation, and the pericholecystic fluid. Okay, so sonogram everywhere. All right. How we're going to treat it? Well, first we're going to do a nasogastric suction, nothing per mouse, and IV fluids and antibiotics. It's going to be followed by cholecystectomy, 6 to 12 weeks. We just wait for the inflammation to subside so we can actually take it out and not having any friable tissue, and things can heal easily. Emergency cholecystectomy can be needed if there is generalized peritonitis, or if there is going to be an emphymatous cholecystitis, which is suggestive of perforation or gangrene. So those are the two things that we consider if we are going to do emergency cholecystectomy. It can be done for generalized peritonitis or if emphysematous cholecystitis. Okay. Now we're done with the cholecystitis. Let's talk about the ascending cholangitis. An ascending cholangitis is an obstruction of the common bile duct, and which will cause obstruction and ascending infection. So common bile duct obstruction, and then ascending infection. It's going to be, again, high fever. It's going to be very high white blood cell count. The key findings are high levels of alkaline phosphatase and high levels of total bilirubin and direct bilirubin with mild elevation of transaminases. So we're going to do the bilirubin and the alkaline phosphatase and so on, and we're going to see very high levels of alkaline phosphatase, high levels of total bilirubin and direct bilirubin, and mild elevation of transaminases. It says there is something called Raynaud's pentad, 5 things. It's going to be jaundice, fever, abdominal pain, altered mental status, and shock. This is something we can find in the ascending cholangitis. The treatment is going to be IV antibiotics. Of course, it's going to be emergency decompression of the common bile duct. It's going to be life-saving. Ideally, it's done by ERCP, of course, but we can do it with the percutaneous transhepatic cholangiogram. And really, it's surgery. I think this is obsolete kind of now, but usually we do it with the ERCP. And eventually, cholecystectomy must follow. Really easy. And this is acute ascending cholangitis. I just need to highlight again that this is obstruction and then an ascending infection. We're going to see high fever, high blood cell count, high alkaline phosphatase, high total bilirubin, high direct bilirubin, and just mild elevation of transaminases. Okay? I just want to highlight that again. All right. Now, the last thing here for acute abdomen is fecal incontinence. Incontinence. Fecal incontinence is involuntary passage of bowel contents for at least 1 month in a patient who is more than three. More than three, of course, because he can hold the fecal um, manner, or he can control the the sphincter. Okay, so this diagnosis, how we're going to diagnose here? This diagnosis is made through a combination of clinical history and flexible sigmoidoscopy or anoscopy. And this is the best initial test, actually. So if the test says what is the best initial test in a patient who has had involuntary passage of bowel contents for at least 1 month and he is more than 3 years old, well, what we do is the anoscopy or sigmoidoscopy, flexible sigmoidoscopy. The most accurate test, however, is an anorectal manometry, and this is going to measure how the sphincter is working. Patients with a history of anatomic injury should undergo endorectal manometry. Okay? So, anorectal manometry is going to be different from the endorectal. I'm not really sure. But yeah, okay. So, someone who has anatomic injury should undergo endorectal manometry. Okay. How are we going to treat that patient? The best initial treatment, it's going to be to combine bulking agents like fiber, for example, with biofeedback techniques like control exercise and muscle strengthening exercise and so on. That's the best initial treatment. The best next step, however, is going to be an endoscopic injection of dextranomer, okay, and hyaluronic acid. So dextranomer and hyaluronic acid in an effort to create a pseudosphincter here. So again, we first try to combine bulking agents like fibers and some biofeedback techniques and exercises and so on to strengthen the sphincter. But if it doesn't work, we can inject endoscopically a dextranomer and hyaluronic acid in an effort to create a pseudosphincter here. This technique has reduced incontinence episodes by 50%. If this phase fails, we do a colorectal surgery right away as it is needed. All right. Okay, so now we are done with the acute abdomen, and we're going to start with the pre-operative and post-operative care here. I believe this is a good section. We're going to have a lot of questions and a lot of answering, and we're going to try to guess how our way through it. Okay. All right, I'm gonna stop here. We haven't finished 25 minutes, but 22 minutes is okay. We're almost 23. I'll see you in the next section in 5 minutes. All right, bye.